All right, next we have Linda Dehner. Linda, brings 26 years of experience in emergency medicine, including roles in the emergency department and helicopter EMS. So here you go, Tom. Her background in critical care has shaped her expertise in managing high acuity situations and promoting collaboration, patient-centered care. As a nurse clinician with the cardiovascular emergency department, Linda leads education initiatives for emergency department, EMS, and transport teams, with a focus on improving timely access to advanced cardiovascular care in rural communities across Minnesota and Wisconsin. So please welcome Linda Dehner.
Okay, can you hear me okay? Okay, good. Good afternoon. Thank you so much for that introduction. Rock from the Heart is by far one of our most favorite events to attend. Learning how it all got started, hearing survivors tell their stories, and seeing the determination to educate others in the community is incredibly impressive, and we're grateful to play a small role. I am a cardiovascular emergency nurse clinician at the Minneapolis Heart Institute with Allina Health. My role focuses on two things. One, providing education to rural emergency departments and EMS agencies. And two, lost my spot. Hold on. Improving processes for getting patients to definitive care and making sure teams are there ready to care for them when they arrive. We work with large communities and small communities throughout Minnesota, the Dakotas, and Wisconsin. I'm here today to discuss some acute aortic syndromes with a focus on recognizing unique symptoms and pain patterns, the importance of seeking medical care, and what to expect after arriving at the emergency department. Do I click it? It's not clicking. Oh, thanks. Okay, I'll begin today with a brief overview of aortic syndromes, conditions that affect sections of the aorta in the chest and/or abdomen. The upper illustration depicts normal aortic anatomy. Note the layers of the aorta are comprised of varying thickness and structure. The endothelium is the lining of the intima, which is the thin inner layer. The media is a thicker muscular layer that is structured to withstand the pressure of blood being ejected from the heart. And finally, the outermost layer is the adventitia. The bottom illustration shows a section of aorta, including a cross-section for each condition. Starting with the upper left, you'll see the classic dissection. This accounts for the majority of the syndromes. You can see a significant breach and flap in the inner layer of the vessel. This allows blood to be forced into the medial layer. The more blood coming in increases the pressure within the vessel wall. The increased pressure can then lead to a continued split down the wall of the aorta. Just below the classic dissection, you'll see a discrete aortic dissection. This is a newer diagnosis, which is a tiny tear in the vessel wall and is thought to be a harbinger of a classic dissection. Moving on to the upper right, there's an intramural hematoma. Describes the presence of blood contained within the medial layer, typically thought as arising from a rupture of the small capillaries within the media, which is represented in the picture above by the small yellow vessels. Some risk factors are genetic conditions, hypertension, and chest trauma. And finally, the lower left is penetrating atherosclerotic ulcer. This begins with an ulceration of plaque, which can lead to a disruption in the innermost layer. That allows blood to enter into the medial layer. Trauma to the aorta and ruptured aneurysms are additional life-threatening emergencies, but we'll primarily be focused on aortic dissections today, as they account for 80% of all syndromes. The aorta is the largest artery supplying oxygen-rich blood to our bodies through an intricate web of vessels. You can experience a wide range of symptoms depending on the location and severity of the disease. For example, if you have a dissection that involves the vessels that supply blood to your brain, you can have reduced flow that leads to a stroke. Therefore, you can experience stroke-like symptoms such as weakness in your arms or legs, changes in vision or speech. If there is a reduction in blood flow to the arteries supplying the heart, that can lead to a heart attack. You can experience a change in circulation to your limbs that may cause pain, paleness, or coolness to the affected extremity. If the lower aorta is affected, you may experience stomach pain. If you experience any of these symptoms, this requires an immediate ER visit. I have always heard a phrase taught to medical residents in emergency medicine. When you hear hoofbeats, think horses, not zebras. Meaning the correct diagnosis is usually the most common diagnosis. And that teaches young residents and clinicians to rule out the most common afflictions first. That works well most of the time. But aortic dissections are zebras. No, I did not coordinate with Shelley before I came, just so you know. I know. Early presentation of dissections can easily be ignored by patients and missed in the emergency room if appropriate testing is not ordered. I recently listened to a talk from a renowned expert in the field, and he describes it not as just finding a needle in a haystack, but finding a needle that looks like a straw of hay in a haystack. So it is critical that we teach both communities and clinical staff to pay attention to specific defining characteristics of symptoms, as early identification and presentation to the ER is very important to survival. So just how common are aortic dissections? This slide represents an emergency department study of patients presenting with chest, back, and/or abdominal pain. Of the over 40,000 patients in this study, over 99% of the patients were diagnosed with other disease or no findings at all, leaving roughly 0.6% that were suspicious for dissection. And only half of those were diagnosed with aortic dissection. Heart attacks, pulmonary embolisms, pleuritis, and reflux are much more common. So how do we find these needles in a haystack? When should we think of zebras instead of horses? The most common symptom with aortic dissection is severe, sudden pain that could radiate to the neck, back, or abdomen, depending on the location of the dissection. According to IRAD, the International Registry of Aortic Dissections, 98% of patients present with complaint of chest pain. So we can give healthcare providers insight. Pain characteristics are important. Pain attending the splitting of the aortic wall is usually excruciating and extensive, radiating from the mid-thorax, front or back, through the chest, down the back, even into the thighs or up into the neck. The pain in the thorax or back comes suddenly at its maximum and is often prostrating, inducing a state of shock or even death. This quote was taken from a textbook in the mid-1940s written by Dr. Paul Dudley White. He is frequently referred to as the father of American cardiology and is one of the founders of both the American Heart Association and National Institutes of Health. As a new nurse, I was taught to pay attention to some key phrases that may be more suspicious for dissection. Pain that is described as sharp and ripping or sharp and tearing. But now we know to take note, in particular, of the onset of the pain. The same IRAD data that reported 98% of patients complaining of chest pain also reported that 45% describes this pain as sharp, and only 27% describe it as tearing. But 82% describe it as abrupt. We routinely ask our patients when the pain started and what were you doing when the pain started, but with dissection, patients almost have a photographic memory of the event. They know exactly the moment that it happened. Sometimes you can have a sudden onset of pain with a heart attack, but it will become more constant and continue to worsen. Sudden at its maximum. The unique, almost insidious feature of pain with dissection is that it will not typically get worse. In fact, the pain may subside completely. This is one of the reasons a diagnosis may be delayed or missed altogether. And if we can miss it, you can only imagine how easily it may be dismissed by a patient themselves. So, excuse me for one second. Getting to the ER can be half the battle. There are several reasons we may wait to seek care. We can doubt ourselves that what we're experiencing is a true emergency. There may be concern of costs, long wait times, or feeling like a burden to our loved ones. We may wait and convince ourselves that the symptoms will improve on their own if we just give it a little time, which unfortunately in this case can be lethal. Many patients die at home. For those who have not been seen in the ER, the first process is triage, where the nurse will rapidly assess your condition, check your vital signs. This may occur in a triage area or in an exam room. It may feel like you're being bombarded with questions, and in times of illness, it can often be difficult to recall information. Having a family member with you is helpful to assist and answer some of the questions. Medical history can be crucial to help screen for increased risk. If you have ever had a cardiac procedure, a previous aortic injury or condition, or any connective tissue disorders, family history of aortic dissection syndromes, it is important to share that information with the ER staff. With aortic dissections, we can look at high-risk conditions along with high-risk pain features and a high-risk exam features as an algorithm to achieve a faster diagnosis. Now we need to get to the why. We know chest pain is the most frequent symptom with aortic emergencies. Remember, aortic aneurysms only account for a very small percentage of the patients seeking care in the emergency department for chest pain. Protocols are in place. Oops, sorry, I got ahead of myself. To help the ER systematically, thank you, assess and order testings in a systematic way with efficiency. The goal is to identify what caused your symptoms and what can be ruled out. Initial investigations include vital signs monitoring, physical examination, and laboratory testing. Most emergency rooms utilize order sets. This is helpful to get orders entered quickly and serves as a useful tool to make sure nothing is forgotten. This can be a time when the entire ER staff has made its way to your room and many things will start to happen simultaneously. An EKG is a standard for separating cardiac sources of chest pain, such as a myocardial infarction or MI. Labs are drawn, as some are very sensitive to an aortic diagnosis, while other biomarkers may be more indicative of a heart attack. All of these can tell us a lot about your clinical picture, but ultimately, a definitive diagnosis for aortic syndromes is best accomplished with the use of imaging with CT angiography, as it has a very high sensitivity and specificity for aortic syndromes. It is available all hours in the ED, even in rural facilities, and Tom just said he had to wait all night. I thought of that when you talked. And it is a very quick test to perform. Blood pressure is often elevated in patients presenting with aortic dissection, so the initial therapy will focus on reducing blood pressure and heart rate, as this will decrease the stress along the aortic wall. In complicated cases, blood pressure can be very low as well and can lead to unconsciousness. Rapid diagnosis is crucial for improving outcomes with patients. with aortic dissections due to the high mortality rate, which increases the longer appropriate treatment is delayed. The emergency department team plays a vital role as faster diagnosis and referral to a specialist enhance the chances for survival. The patient's journey must be streamlined from triage nurse to emergency doctor to the medical team for medical treatment if that is decided, or vascular or cardiothoracic surgeons if surgical intervention is warranted. If a diagnosis of aortic emergency is confirmed, things will begin to move even more quickly. Treatment options and next steps will vary depending on condition and the part of the aorta that is involved. For dissections involving the arch or ascending aorta or type A, emergent surgical consultation and immediate surgical intervention is recommended because of the high risk of associated life-threatening complications. Uncomplicated dissections that occur further from the heart and in a part of the aorta that travels downward from the chest into the abdomen can often be initially treated with medications, but may require surgery if there is a decreased flow to vital organs such as the kidneys or intestines. If you've presented to a hospital that does not have surgical capability, your ER physician will discuss the process of rapid transfer to another center with those options. We know that the transfer to a high volume aortic center can result in significantly improved outcomes. That is necessary in nearly 60 to 70% of the cases that do present. Therefore, many centers have developed processes to reduce transfer delays and improve communication between the sending and accepting facility. This moment of diagnosis can be overwhelming for the patient and their loved ones. It may be helpful to elect a contact person who can handle calls and other details, as this is an important time to keep other stressors from entering your world. It is at this time that a multidisciplinary team begins to take form. Members of the cardiology team connect with cardiovascular surgery as well as surgical vascular surgeons, hospital personnel, and to expedite surgical intervention. The best option for surgery is discussed with the team and continue communication with the sending facility if applicable. Every effort is made to get the patient to the OR as fast as possible. Many times a patient arriving to another facility will have arrangements to go straight from the transport crew directly into the operating room. Transport by helicopter can save a great deal of time, and it is the preferred transportation for a longer distance. But it may not be an option due to inclement weather or availability. Ground EMS transport by ambulance is the most appropriate for shorter distances, and it is a secondary option if flight services are unavailable. As the patient is being transported, surgical teams are preparing the OR suite to be ready to provide immediate care the moment of arrival. The patient will be taken directly to the OR whenever possible. For process improvement, developing a plan for early recognition and initial treatment can significantly reduce diagnosis delays. As I mentioned earlier, order sets are very useful. Once the patient is diagnosed, there are other protocols in place to streamline the transfer process to the most appropriate facility. Facilities also use a checklist to ensure the best care and preparation for the OR. Some other resources for process improvement. Our program has created an app that we encourage doctors, nurses, and paramedics to utilize. It provides access to call to arrange for a transfer with a touch of a button. It also includes protocols, treatment, and transfer checklists that are quickly accessible. Additionally, there are other clinical resources including a link for educational podcasts by our team at MHI and other educational tools and information. Simulation is one of the tools we utilize with our outreach education. Bringing our equipment and allowing staff to run a simulated event in their own space using their own equipment provides meaningful education. It allows facilities and EMS agencies to identify educational needs and potential delays so they can effectively improve processes. And I'm just gonna back up one. Next time I come, I'll make sure we have a picture of Hal with a Rock from the Heart t-shirt on for you guys. Thank you so much for allowing us to be here with you today. I'll be happy to answer any questions you may have available, and I'll be available at our booth all day as well. Thank you. Thanks.
I want to thank everyone for attending today. Thank you to obviously all the providers and speakers that were here today. Thank you for attending. Thank you for all the great people and partnerships that we've made over the years that has helped make this possible.